Okay, good. I see a red button. All right, well, good morning. Welcome to the PCEP for, it is not November of 2020, it is April of 2023. Just a little error in filling out these things. So today we're going to talk about or review some of the basic emergencies in children, all part of our yearly and our yearly PCEP, which is designed to give everyone enough CME credits, or most of the CME credits you need to re-up your certifications. This will be a mostly review. There will be some new stuff in there, but mostly a discussion of how we manage some of the common emergencies of children that you're going to be seeing. First thing is to look at, this was developed in 2000 by the American Academy of Pediatrics. It is basically it's the pediatric assessment triangle, and it's essentially the quick gestalt view of looking at a child to decide if they're sick or not sick. So basically, it's the first, along with the scene survey, it's the first thing you're going to do. And basically, you look at appearance, the mental status, and muscle tone, which has to be appropriate for the child. Obviously, a newborn has a different muscle tone and awareness than does a 1-year-old or a 2-year-old child. Muscle tone, floppy children are always very sick. The usual thing for most children is they resist your examination, especially as they get to be about 2 to 3 years of age. Gross abnormalities of mental status and muscle tone require immediate intervention and transport. Generally, the kids are in shock, whether it's septic shock or respiratory-induced shock. Look at the work of breathing, the respiratory rate and effort, and that's why you need to be familiar with what the ranges are of normal for children. There'll be, all of us have little cheat sheets for that, but generally speaking, a respiratory rate above 30 per minute is abnormal for most everyone. Circulation, skin signs, color, capillary refill. We do capillary refill particularly on smaller children because it's your blood pressure is sometimes difficult to get, sometimes difficult to have the right size cuff, and just difficult to find it. And capillary refill is a good indication of shock of whatever origin, but generally in children it would be septic shock. Use the findings from your patient assessment triangle to determine whether or not the patient requires urgent care. Also assess the ABCs, treat life threats, transport. If the condition is stable, then you can go ahead and do the full primary and secondary assessment as you're establishing. Happily, just like adults, the vast majority of children we see are not critical, but it's the critical ones that we have to identify quickly and get to definitive care. Respiratory emergencies is extremely common in children. So infants and toddlers are at high risk for aspiration, and generally they can obstruct the airway with, like this block is not going to obstruct the airway because the kid's not going to get that in his mouth. But we've all seen multiple small objects that children put in their mouth and then try to swallow, but end up inhaling instead. Peanuts used to be a common aspiration thing with children. Would they be able to obstruct one bronchus actually? children who are vomiting can sometimes aspirate, and of course, children, just like adults, the general thing is that an aspirate is going to go down the right main stem bronchus first because of the angle and the way that gravity works in getting things down into um, uh, those curved spaces. Mild obstruction, a child is generally awake. Stridor may be present. They may be drooling because, uh, especially if they get a obstruction in the, like a coin that goes into the esophagus and then obstructs the airway as well. They'll get some stridor because it's an upper airway thing. They'll have increased work with breathing, but generally good color. They're moving air and then they're oxygenating. With severe obstruction, of course, the child becomes cyanotic and ultimately becomes unconscious due to anoxia or hypoxia. Oops, kind of didn't make this work correctly. There we go. With partial obstruction, obviously we sit the patient up, having her cough. Transport obstruction is not cleared, or if you're suspicious of an aspiration. With complete obstruction, follow the American Heart Association protocol for complete obstruction. Use a laryngoscopy if the patient's unconscious with attempt to remove the McGill forceps. If you can't remove it and you're unable to ventilate, we consider a cricothyrotomy in an older child or a needle jet insufflation in pediatrics. Happily, that's a very rare occasion, and to be honest, I cannot recall a single case in my roughly 30 years here as MPD that where we've had to do a needle jet on a child. It doesn't mean it won't happen, but and so we should be prepared for that. More common respiratory emergencies we see. Well, one of the most common is croup, which is a viral infection of the upper airway, typically abrupt. Although if you take a careful history, often the child had had a cold for a day or two, and then had awakened, seeming to be with air hunger and quite distressed the previous night, and then got better as he or she uh, stood in the crib and cried a little bit. And then the parents didn't think much of it, and then it happened again the next day. It's usually worse the second day. Your assessment triangle typically reveals an alert child or toddler with audible stridor, but they're active and they're agitated. They do not like what's going on. They'll have a barky cough. There'll be some increased work of breathing, but with normal skin color. That's your usual case. But if that's severe, with a barky cough, they'll also have stridor at rest. So in the previous case, mild case is stridor when they have activity or when you agitate the child. Now, with severe symptoms, they have this barky cough at rest. Sounds like a seal bark. They'll have retractions, they'll have significant distress, and they will be very agitated. They're frightened. They're showing air hunger. Um, the, you may think that they have impending respiratory failure, uh, particularly if their LOC is depressed. They have stridor at rest, severe retractions, and cyanosis. Now, something we don't see much anymore in young children, but I suspect we will start seeing it again as people are going away from vaccinations, um, uh, is epiglottitis. Epiglottitis has been in infants and young children has been caused by the Haemophilus influenza bacteria, which used to be the commonest cause of uh, severe ear infection in kids. And so we've developed a vaccine against Haemophilus influenza bacteria. And so we knocked out the ear infections, which cause meningitis often, and as a sort of an advantage is it's also decreased the amount of epiglottitis. Epiglottitis is a severe infection and inflammation of the supraglottic structures, including the epiglottis. Classic presentation is this is a sick child. This person has a high fever. They're very anxious. They sit in a sniffing position because they can't breathe adequately without being in the sniffing position. They are drooling. There's copious drooling because it's extremely painful to swallow. So they can't swallow any of their secretions. And their inflammatory process is producing lots of secretions. They have an increased work of breathing because their airway is closing off, and they will often have a stridorous sound to them. But the most impressive thing, and then they'll have pallor and cyanosis if they're not oxygenating correctly. So the most impressive thing about them, though, is this extreme drooling and this sick child appearing. Now, like I say, it's rare if the children have been immunized. We start the Haemophilus influenza at about, I think it's about 18 months. And so it's rare before that anyway. And now we are seeing epiglottitis caused by varieties of staph infection, but it also can occur in adults, but it's still pretty rare. And of course, the larger you are, usually the better, the more easily you're able to handle this swelling. But it becomes it becomes a surgical emergency often. So your protocol for dealing with pediatrics with upper airway issues are if patient is if they have audible stridor at rest, if you're thinking croup. Now remember, it's at rest, not when disturbed. Patient gets 20. Patient who's between 20 and 40 kilograms. You use racemic epinephrine, 0.5 cc's. Now, by a nebulizer and a mask. An alternative, if you don't have racemic epinephrine is just a form of epinephrine that has both the dextro and the levo form of epinephrine, and it's not magic. It has a little less beta effect, so a little less heart rate stimulating. But if you don't have racemic epinephrine, the same dose, 0.5 of epinephrine via nebulizer works just fine. For a child that's under 20 kilogram racemic epinephrine or epinephrine at the 0.25 mil nebulized. And if the child deteriorates, ventilate with a BVM. If you can't effectively ventilate with a BVM, do intubation. If complete, except there's a precaution with patients who have epiglottitis. Now, with missing maybe not. Something happened in this one. For patients with croup, we would also give them. We'd also use dexamethasone. If you needed to use the racemic epinephrine, or epinephrine, I would give them dexamethasone as well. The dex is 0.6 per kilo. Asthma, common in children. Now, a lot of times in young children who have wheezing, there used to be a tendency to call that asthma, but we don't, pediatricians don't like to call kids asthma until they're a little bit older because there are a lot of other um, minor or less severe causes of wheezing in children that's intermittent. So we generally don't call an asthmatic, but if the characteristic of asthma is wheezing, and my recommendation is you always use wheeze medicine to treat wheezing. So uh, three main components of asthma: bronchospasm, so the bronchi narrow; inflammation, it is an inflammatory process. And because of the inflammatory process, you end up with increased mucus production. Part of the inflammatory process is copious amounts of everything from eosinophils and basophils, phagocytes, etc., that invade and get into the bronchi and into the alveoli. Uh, but the main thing is you've got ultimately narrowing of bronchial tubes, both from bronchospasm and from mucus pluggings and mucus narrowing. Triggers of asthma, allergens, secondhand smoke has been implicated. I know you noticed that there was a little bit of a brouhaha, sort of manufactured couple 2, 3 weeks ago when it was suggested that, well, because the report came out that um, there was an increased severity and incidence of asthma symptoms in children who live in houses that have that have natural gas stoves. Simply because there's you know gas off-putting from the stove. Um, no one is going to take away your stoves, but it's the same thing as secondhand smoke. It's hard sometimes to get parents to stop smoking around their children too. Cold air can trigger asthma. Exercise. I used to have exercise-induced asthma for about 40 years, and then it went away magically. Um, Respiratory infection can trigger the asthma response, and emotional stress can, if you have a well-established asthmatic, um, uh, particularly what makes it difficult in in children, particularly teenagers. Now, my treatment for asthma is basic. We use albuterol, weight-based, along with Atrovent for the first dose. Now, Atrovent is probably not, or ipratropium. It's not truly indicated after the first dose of albuterol Atrovent, because it's kind of a waste. It has a half-life of about 3 to 4 hours, so it's kind of wasted if you're going to do another treatment. But it won't harm the patient. So if you only have a Duoneb, then you'll use that again. But if you have albuterol and Atrovent separately, I would recommend the second dosing of your MedNeb, or a continuous MedNeb. You just use straight albuterol. Then I would give the child Solumedrol, or child or adult, Solumedrol at 2 milligrams per kilo, or dexamethasone at 0.6 milligrams per kilo. Now, for most of the cases that you're going to see are going to improve with that first dose of Atrovent. and they should still get the Solu-Medrol, but persons who don't improve or who seem to be getting worse and having signs that they're getting worse, you're going to have to add something else to it. And my order of adding things to it would be epinephrine 0.1 mic per kilo per minute for status asthmaticus, and start dripping and start adjusting the drip as required. And then I would give magnesium sulfate, because I would not give the magnesium sulfate before I started the epinephrine, because it takes longer time to get the magnesium. Is not a drug you put in fast, really. So you'll take a little bit of time to put that in. I would get the epinephrine drip going, then get the magnesium sulfate going. And so it's the albuterol, repeat albuterol, Solu-Medrol in the meantime. And obviously you can, depending on the age of the child and the ability to cooperate, the child not only needs oxygen supplementation, but may need to have a CPAP can be tried if the child is old enough, and you may have to do some assisted ventilations in the severe case. But albuterol, Solu-Medrol, and then follow with epinephrine and magnesium. So hopefully with an aggressive albuterol and the Solu-Medrol, there'll be a minimum number of cases we have to go to the extreme. Bronchiolitis. This is most commonly caused by RSV. It's extremely contagious, and adults can get it. This last flu season, they've had quite an issue of adults with RSV. Typically happens in the winter during flu season. Younger kids, usually less than 2 years of age. Characteristic are mild to moderate retractions and tachypnea, diffuse wheezings, and crackles, mostly expiratory crackles. So, the kind of crackles you get, the rails you get from congestive heart failure, for example, are mostly inspiratory and then expiratory. So inspiratory crackles happen first in congestive heart failure, but expiratory crackles happen first in RSV. There's mild hypoxia usually unless the patient gets severe, and then there's increased respiratory effort, tachypnea, nasal flaring, retractions, using accessory muscles, grunting. Their SpO2 will be less than 95. And they can go to acute respiratory failure, mostly from fatigue with apnea, which means in that case, you'd have to ventilate the child. Now, treatment of acute bronchiolitis with mild to moderate respiratory distress is O2, blow-by, nasal cannula, or a mask, keeping the SpO2 above 92. Obviously, we like it to 94, and monitor the CO2. And if they're wheezing, a trial of albuterol, 2.5 milligram via nebulizer. If they have improvement, you can use it every 10 minutes. Now, I'm here to tell you that all the studies show that albuterol doesn't work every time. It doesn't work all the time even. So if it isn't working, you don't, if it isn't working, then you don't have to do it again. But if it does work, if it seems to improve their wheezing, then you can do that every 10 minutes on the way in. Once with severe respiratory distress, the same thing. Try albuterol. If it works, great. If it doesn't work, prepare for positive pressure ventilation with the BVM. Think about, you may have to intubate this child. especially if their ETCO2 is above 55. That's why we want to monitor their ETCO2. Or if you can't maintain an SpO2 above 85 by any other means. Now, they've done all sorts of things with, it turns out, steroids are not thought to be of value. Suctioning is not necessarily thought to be of value, but nasal suctioning, short bursts, especially if they have copious mucus, is possibly helpful. Mostly, you end up helping this child's ventilation and bringing them and taking them to the ER. There's not much magic that can be done. Now, pneumonia. Pneumonia is not common in newborns because they're usually not exposed too much. But if they do get an infection and they have usually streptococcal pneumonia antibody from the mother as a passive immunization, so they generally don't get pneumococcus infection. But if they get a pneumonia, it's characterized by poor feeding and irritability with tachypnea, retractions, grunting, and hypoxemia. So you would look at your pediatric assessment triangle and say, yep, this is a sick kid and he's having trouble with the retractions, and grunting, and hypoxemia. It's probably his lungs that are causing it. You're not likely to hear crackles or rales in his lungs. And it's the poor feeding, irritability, and your visual cues that are going to give this away. With infants, they'll have a cough. You notice the newborns don't have a cough. Infants will have a cough, tachypnea, retractions, hypoxemia, accompanied by persistent cough and congestion, fever, irritability, decreased feeding, and they may become septic. Children and adolescents have a fever, cough, congestion, chest pain, dehydration, lethargy. They also may present in shock, possibly septic. Pneumonia, supportive position of comfort. Make sure the airway is patent. Oxygen supplementation, maintain your O2 saturations above 90. Manage respirations. Treat wheezing as needed. If they wheeze, treat it with wheeze medicine. And fluids, particularly if you suspect shock. Pertussis is a disease, bacterial disease coming back. It was pretty well wiped out with childhood immunizations, but because those have fallen off and repeated immunizations are also falling off, pertussis has made a comeback. It's highly contagious, spread through respiratory droplets. Symptoms are similar to the common cold, and for an adult, the worst thing about it is usually significant bouts of severe coughing. Coughing can lead, with extreme coughing, to cyanosis and hypoxia, but generally speaking, adults don't generally die of this. However, children do. Treatment is entirely supportive. Maintain oxygenation and manage airway. Obviously, in the severe cases, need to be hospitalized, start on antibiotics specific to pertussis. So by supportive treatment, if you need to intubate and ventilate the patient or do a ventilate assistant, of course, you have to do that. Septic shock. remember, septic shock can be, you suspect an infection, and the infection is manifested either by hypothermia, subnormal temperature, or hyperthermia, above normal temperature, generally very hot. Kids, generally speaking, will be hyperthermic with their septic shock. And then you suspect the infection, either hyperthermia, hypothermia, and then there are clinical signs of inadequate tissue perfusion, altered mental status. And with a child, that means a child who doesn't react normally to your evaluation or to the things you do, like start an IV on them. If a child is, quote, floppy and lays there and doesn't squirm when you start an IV, there's something wrong with that child. That's altered mental status. Decreased capillary refill, very important to check with kids. It's the number one clue that they have suboptimal perfusion, which means shock in any other words. Mottled, cool extremities, same thing. They're now shunting. They're now trying to maintain blood and blood pressure in the central, and at the expense of the extremities. So they're cool and mottled. Decrease urine output. You're not going to be with the child, hopefully, that long, but you ask the mother, when did they last have a diaper change? When did they last urinate that you knew? Anyone who has kids knows that kids pee all the time, especially when you're going to go on a trip. But you need to, they have a normal urine output, and a baby has to have several wet diapers a day to be normal. And if you can get blood pressure, if the child is old enough, get a blood pressure. If they're hypotensive, you can't find radial pulses in older kids, that certainly it's under 70 generally. You should be able to get a blood pressure. Protocol for septic shock in children. Pediatrics, maintain oxygenation. A fluid challenge is necessary. It's 20 mils per kilo, repeated times 1 before you would have to ask for a medical control consult. So you try to get their blood pressure up to more appropriate for their age or sex. And it says, or if symptoms of pulmonary edema do, there's almost no pulmonary edema that's going to develop in a septic child or a shocky child unless the child is shocky because of a cardiac issue. Because children just don't, children don't normally get congestive heart failure, and they can handle fluid. If the patient is still hypotensive, and my rule of thumb is if I'm gotten nowhere with that fluid challenge, or it hasn't improved and to my satisfaction, to the point that I start another fluid challenge, then I would start that child on a norepinephrine drip, and I would choose norepinephrine generally because the child's heart rate is probably fairly tachycardic, and norepinephrine will deal with blood pressure, but will not generally elevate the heart rate. Now, if you don't have norepinephrine, you could use epinephrine alternatively. Then with the norepinephrine, I'd increase it by 0.1 mic. So I start out at 0.1 mic per kilo per minute, and I'd increase by 0.1 mics per kilo per minute every 5 minutes. Thing with shock in children is it's important to get them. The longer you're in shock, the worse the ultimate outcomes of both morbidity and mortality occur. So I would want to be relatively aggressive at that. There was a recent article about the differences in shock outcome if they gave 2 fluid challenges and then the pressor, or 1 fluid challenge and then the pressor, and um, there was no apparent advantage to giving 2 fluid challenges before you started uh, the pressor, and indeed there might have been some disadvantage to that. Obviously, you notify the receiving facility that you have a septic shock alert patient. Cardiogenic shock is, as they say, rare but not uncommonly found in children, but pump failure is generally due to congenital defects, and or to a rhythm, and so the family will generally know about that. You probably that they'll be able to inform you of that problem, and the kind of things that include patent ductuses and right to left shunts, either ventricular or intraseptal or intra-atrial septal defects. Things that were found close to birth, and they're waiting for the child to get to be a certain size before they can get appropriate surgery. Now, probably the most common causes, though, are rhythm disturbances, which are also based on usually some congenital defects, and supraventricular tachycardia is the most common, with probably atrial flutter being or PAT being the most common. Myocarditis or carditis or other infections can cause cardiogenic shock. There were obviously some cardiac myocarditis issues with COVID that resulted in some children being treated for minor forms of cardiogenic shock, and then most of them had no problems after the initial stabilization. Near drowning can of course cause what looks like cardiogenic shock with pulmonary edema, but it's not truly cardiac in origin. It's from the uh, ARDS and the drowning. It's really pre-cardiac. Signs and symptoms of cardiogenic shock, well, same as any other shock. Listlessness, lethargy, decreased LOC, increased work of breathing, impaired circulation, skin is pale, mottled cyanosis, sweating with feeding. This is often, with little kids, with babies, infants, it's difficult to hear rels. You sometimes could do that, but mostly it's the suspicion, and often the first thing that the medic will notice is that, or find out in the evaluation of the child, is that they're tachycardic, and then put on your leads, find out that the kid is in supraventricular tachycardia. And you treat supraventricular tachycardia as you do any other supraventricular tachycardia. If you think it's standard PAT or supraventricular tachycardia, it's treated with my brain just stopped. Adenosine. We don't generally shock kids, but we can. Usually adenosine works quite well for supraventricular tachycardia in kids. and you manage it as any other shock. They'll need fluid replacement if that's the problem, etc. All right, on to seizures. Seizures are a dime a dozen. It's common in this business, particularly febrile seizures. So it's a simple febrile seizure, generally it's fever in a child aged 6 months to 5 years. It's generally a single seizure. It's not how fast, it's not how high the temperature is, it's how fast the temperature went up. So a slow rising temperature to 104 will probably not cause most people to have a seizure, but if they jump from 99 to 101 in less than a minute, they'll probably seize. Generally, the single seizure or febrile seizure is over by the time you get there, and there's no neuro abnormality by exam or history. The seizure would have lasted less than 15 minutes. And as I say, it's usually over by the time you get there, because by the time mom and dad call 911, dispatch occurs, and you get on your way and you get there, you probably spent a minimum of 10 minutes from the time the seizure was first reported to the time you get there. It's generally over by then, and the kid is awake, unhappy, generally unconsolable, held by mom, generally, and febrile, but obviously no seizure going on, and he's postictal. A simple seizure is not caused by meningitis, encephalitis, or any other illness. It's generally a clonic or generalized tonic-clonic seizure, the true major motor seizure. Now, in a complex seizure, it could be focal or prolonged, but so if it's prolonged more than 15 minutes, or if they're actively seizing when you get there, or if they have multiple seizures occurring in close successions, that's a complex seizure, and we would call that, essentially call that status. My rule of thumb is that nobody seizes beyond 10 or 15 minutes. So if your patient is in status seizure, continuous seizure, repetitive seizure without gaining consciousness, Versed 0.2 milligram per kilo IN, 0.3 milligram per kilo IM, or IM. You could give it, if an IV is available, Versed 0.1 milligram per kilo, max of 5, and you can repeat every 5 minutes till the seizure stops. The same thing with the Versed nasally or otherwise. Generally speaking, it will stop. Monitor the patient's respiratory status closely because of the Versed. Febrile seizures are generally found between the ages of 1 to 6, usually short in duration. If the fever is greater than 103 and seizing, give the Versed and then cool the patient. Give the Versed before you give the acetaminophen. If on arrival the patient's not actively seizing, you don't need an IV, and you don't, if they're just postictal, they're awake, otherwise they don't need the Versed. But I would prefer, if you believe that the child is still seizing, if they're not obviously postictal, awake, obviously not seizing, if they're just quiet, not awake, staring straight ahead, or eyes deviated, that's still a seizure. Give them the Versed. And of course, you would check blood glucose as well. And any hypoglycemic or first-time pediatric seizure patient has to be transported. Now, if they've got a history of febrile seizures and the parents have instructions from their pediatrician on how to follow this. I would, if they say, well, we want to stay home, or we want to, this has happened before, this is what we do for it. Obviously document that. You can get that as a, you can sign that off as a, um, as a refusal. If you have any concern that the patient should go to the emergency department, though, and the parents don't want to do it, then you need to contact medical control and discuss that, and have the physician talk with that family too. Brief resolved unexplained event, a BRUI. This is an event lasting less than a minute in an infant less than a year of age, associated with at least one of these following things: either cyanosis or pallor, absent, decreased, or irregular breathing, marked change in muscle tone, altered level of responsiveness. Treatment. It's done by the time you get there. That's by definition of a brief, resolved, unexplained event. Support ABCs as needed. Obtain and document any complication of pregnancy, birth date, gestational age, etc., past history of the child, fever, recent infection, prior episodes, underlying medical conditions. Obtain and document a description of the event, including symptoms. Is there any inciting event, anything that made this happen, or happening just at the same time they went into this? Any resuscitation attempts before EMS arrival? Put on a cardiac monitor, follow dysrhythmia, assess protocol, assess blood glucose, transport to an emergency department, even if the infant currently appears in no distress. If the family, parent, or guardian wishes to refuse transport, online medical control contact is mandatory. They have to talk to the doctor. BRUI is a group of symptoms. It's not a specific disease. It's most common in infants under a year of age. It can happen up to 2. Consider non-accidental trauma. The child may appear normal by the time you get there. Serious underlying causes include pneumonia and sepsis, bronchiolitis, seizure, sepsis, intracranial hemorrhage, meningitis. So there's some bad things. More frequent in premature infants, which is why we want to get that kind of a history, or infants with other health conditions such as cystic fibrosis, bronchiolitis, congenital heart disease. All those things will come out in your history. Sudden infant death syndrome. Infants are usually less than 6 months of age, sudden without apparent cause, and during sleep. It may be impossible to differentiate SIDS from suspected child abuse. What do you do with the SIDS? You do CPR unless there are obvious signs of death, rigor, lividity, etc., cold babies. Follow protocol for cardiac arrest. Resuscitation then is terminated only on order of base station physician, or if there's a family physician at the scene, which is almost never the case. Support the parents, avoid questions or comments. Observe carefully and note location, position of child, objects surrounding a child, behavior of all adults present, the explanations provided, vomitus in mouth or foreign body. Sometimes there's a little blood in the mouth or blood on the bedclothes. Report all observations to medical control through your IR and also to the medical examiner. Now, injuries. Injury mortality surpasses deaths from all other childhood illnesses combined. In other words, trauma. Anatomy, physiology, and other mechanisms produce distinct patterns of injury that are both related to age and to stage of development. Neurologic and respiratory derangements far exceed hemodynamic derangements. So you're going to see neuro-respiratory changes before you see shock, or more commonly. So kids have large heads, small jaw, short, narrow, funnel-shaped airway, soft cranium, open fontanelles. They need more development for cognitive functions to occur, so they can't talk to you, they can't explain what's going on. Kids have a prominent occiput, so you need a pad, a 1-inch pad under the torso for neutral position of the spine, head and neck. Cervical spine is extremely flexible. That's why kids need to be restrained in appropriate and correctly done car seats, because they have this big head with extremely flexible spinal ligaments, and you can get ligamentous injuries very easily with deceleration injuries with the head going rapidly forward. That's why kids sit backward in their little seat. They have normally anteriorly wedged vertebra, which means that it flexes forward very easily, flat facet joints, so there's no resistance to flexion, and they can get what's called pseudo subluxation, particularly on X-ray. It looks like they've subluxed when there's normal, but kids can get severe injuries to their neck by deceleration injuries in a vehicular crash. Their chest is very soft, pliable. Their ribs are horizontally aligned, both anterior and posteriorly, and they have weak intercostal muscles compared to what it's going to be as they get bigger. Rib fractures indicate incredible force because the ribs are so pliable that if you fracture a rib, that was an incredible amount of force that hit that. So that means that force is transmitted into the chest cavity itself. When children get a tension pneumothorax, it's very poorly tolerated because of the soft, pliable chest. As you get a pneumothorax, it rapidly shifts the mediastinum away from the side of the tension and impedes venous return, and that's why a child with an tension pneumothorax, even a simple pneumothorax, is extremely difficult to resuscitate without placing a chest tube. Abdomen is soft, thin, and the abdominal organs are very much in the abdomen itself. So as an adult takes a blow to the upper abdomen, the liver is primarily protected by the rib cage because it's up under the 10th rib generally, and so it's relatively protected. And of course, we get enough liver injuries in it, but children, their liver and their spleen is very vulnerable because it's right where right where a blow to the abdomen would strike it. They also have a high riding bladder, and the bladder can be injury. So multiple injuries to the abdomen are common in motor vehicle accidents or pedestrians struck by car accidents with children. Now, important that you review again the age-specific vital signs for children. Um, uh, but remember that children have a smaller blood volume. They also have a decreased functional residual capacity of the lung, but they have a vigorous compensatory response to the initial injury, so that with uh, with blood loss from an injury, um, even with the smaller blood volume, the child can often keep its blood pressure normal or relatively normal for a long time, because it can get a great sympathetic response, which causes vasoconstriction, which will maintain blood pressure until it can't. And so the first sign that we generally see that the child has lost some significant volume is, of course, heart rate then. That's why we bet on heart rate and also on capillary refill for as a substitute for blood pressure. Your blood pressure may often be normal, heart rate will be up, and capillary refill will be prolonged. So once they go beyond, they can generally tolerate up to a quarter blood loss without showing any change in their um, blood pressure. But then they'll suddenly crash and be obviously in shock. But that's a long time. That's late. And that's almost too late then. That's going to be a difficult resuscitation, because when you go into severe shock, you get all the attendant things that go with multi-organ failure. Also, little kids, pediatrics have a high body surface area to the mass and very thin skin, less insulation, so they get hypothermic very easily. So children in trauma become hypothermic, adults in trauma become hypothermic as well, but kids get hypothermia really quickly, particularly if there's any shock associated. So protect them. Child abuse has unfortunately not gone away. Be alert to in any trauma situation. Uh, be alert to finding suspicious, well, not necessarily in motor vehicle accidents, obviously, but be alert to suspicions of child abuse. The caregiver explaining mechanism of injury, the conflict with what you actually see as an injury, suspicious injuries. Little kids don't burn themselves with cigarettes. They don't generally have multiple bruises of various ages, although one of my nephews did, just because he ran into things a lot. Belt marks, etc. Children with a history of repeated injuries, blame placed upon others, dad blaming the mother, mother blaming the dad, that kind of thing, or blaming the other children. Procrastination by the caretaker in seeking age. Don't forget that sexual abuse can accompany physical abuse and may be present without apparent signs of physical abuse. And don't forget that boys and girls are subject to sexual abuse. In your evaluation, you do treat any injury per protocol, transport without delay, document environment, including temperature, note the reaction of all the adults, note clothing, stains, conditions, bring clothing in with the patient, encourage the caretaker to allow transport of the child to the hospital. Should the caretaker not allow transport, notify law enforcement. This becomes a legal matter. Support and reassure the child, be non-judgmental, be supportive of the family concerns, etc. Now, in an infant child death scene, including SIDS, Notify appropriate agencies if not already on scene, including law enforcement and medical examiner. That's generally taken care of, but you will call the medical examiner after the fact. Document the following: position of the child when originally found, where the infant was found, in the crib, waterbed, bassinet, etc. Position of face, was it covered by blankets, bedding, etc. Was the infant or child sleeping alone? Any airway obstruction or secretion in the airway, any secretions known in the child's bedding, treatment rendered prior to arrival, be cognizant of evidence. Resuscitation takes precedence, but try to preserve any evidence. Document all invasive procedures, including IVs, intubations, etc., as you would normally. Now, pediatric trauma, we divert under your protocol, we transport pediatric trauma entry, all pediatric trauma entry patients to pediatric level 1 hospital unless the closest hospital is necessary for airway control, vascular access, or if the child's in arrest, we would not divert past a hospital for stabilization or attempted stabilization. For long transport or traffic issues, consider life flight. You could use the helipad at either South Southwest or Legacy Salmon Creek as a rendezvous. Now, obviously, in the more rural areas, there'll be other closer places to go that you would pick the child up, that they would pick the child up. Hmm. I'm missing a slide here, so I must have picked up the wrong one. Well, we'll go. Uh, I wanted to mention that, and we did add to this, but I probably picked up the wrong version to load into this today. We did put in the your red and green trauma um, uh, new trauma triage tool. And the trauma triage tool, there's some specific things which you want to highlight and remember about children. And one of them was we have changed under the red category, we have changed the definitions of uh, uh, of shock, basically, uh, based on blood pressure, that a child under the age of 10, we would have a child would have a normal blood pressure would be 70 millimeters mercury plus 2 times the age of the child. So if you had a 10-year-old child, that would be 20 plus 70 or 90. So if the blood pressure is less than 90, we're going to consider that to be likely shocky. And that would be an entry. So a child with a blood pressure of a 10-year-old with a blood pressure of 70 would be in the shock range. That means a 1-year-old would have 70 plus 2, or anything less than 72 would buy that kid an entry as well. The other things is that falls in the yellow category, falls of greater than 10 feet for adults or peds will buy you a trauma entry into the yellow category, and specifically for children, a fall from with infants, low-level fall with suspected head injury is in the category of paramedic discretion. That child would also likely become, if you have suspicion the child is likely going to become a trauma entry. And once again, pediatric trauma entries should go to the pediatric trauma hospital. Now we have to talk about, because Mark pointed out that one of the OTEP requirements is to do a short discussion, a brief discussion of the patient of pediatric patients with special needs. And that starts out with children who have congenital issues that require tracheostomy tubes and or artificial ventilation. And the most common problems you're going to see with tracheostomy tubes is obstruction, generally with secretions. And your assessment is going to have respiratory distress. And then you assess the tube position, suction the tube. If they don't improve, you may need to remove and replace the tube. Now, obviously, it'd be a good idea if we could suction the tube and get them appropriate enough to be able to transport without having to do that, or if we don't have the appropriate tube. Generally speaking, the caregiver should have replacement tubes. They generally have already, they've been trained how to suction and do that sort of thing. So generally speaking, this is a child that you'll have to plan on uh, uh, assisting, trying to get their oxygenation up, and then getting them to appropriate emergency care. It will not be one you leave at home. Gastrostomy tubes, you get called on them. There's when generally they're not flowing right, they're obstructed, and these are surgically placed into the stomach, and usually you would just do supportive care and transport the patient, because this will have to be replaced. Central venous catheters like PICC lines are inserted for long-term IV access, placed into large central veins, and complications include infections, obstructions. The catheters can be broken or dislodged. Once again, this is not something we treat at the same. We'll transport. You treat any symptoms, any issues you find with the patient at that time. Generally speaking, if they have an infection, they'll be obvious. They may be septic from that. Ventricular shunts are put in to relieve internal hydrocephalus. The shunt actually is put into the ventricles of the brain, and then the tubing exits the skull, goes down subcutaneously along the scalp, down the neck, down on the chest wall itself, then pops into the abdomen where it then drains. Now, without adequate drainage, the fluid accumulates and the pressure increases in the brain, and the kid will get hydrocephalus and get the symptoms of hydrocephalus, which will be altered level of consciousness, possibly some irritability, some somnolence, not feeding and acting normally. These things have a reservoir and a pump on it, which the parents will have probably already tried to pump, but these things get plugged somehow from the fluid. So that you would do supportive care, transport to the emergency department. The kid has to go back to surgery to have the pump, the shunt revised. These are medical emergencies and they get neurosurgical evaluation. So it's just your cardiopulmonary monitoring, keep their O2 levels up, etc. Now, special needs kids. Standard assessment sequence. Look first at your pediatric assessment triangle. Is this kid sick? Do you have to leave with this child immediately? Is this an urgent, or can you take your time and do better assessment? Ask parents questions to establish baseline neural function and physiologic status. Meet the child at their own developmental level. Now we're going to be talking about special needs kids, mostly kids like kids with autism spectrum. Work with the patients to try to get the child back to their own physiologic baseline. And if you can, transport the child's caregiver with the patient. Now, with an autistic patient, the spectrum neurologic disorder manifests as difficulties in communication, social understanding, and/or cognitive development. They have often repetitive and restrictive behavior patterns. Disability, though, and the typical behavior varies in all. There's no common thread except that it's difficult to communicate. Now, some of the characteristics of difficulty communicating is they may not recognize you as a first responder or your vehicle or a badge or a uniform. They may only see you as a threat. They may not understand what's expected. They won't respond to commands. They'll run or move away when approached. They'll be unable to communicate with words sometimes, or repeat only what is said to them, or communicate only with sign language, pictures, or gestures. You have to ask the parents or the caregiver how they usually do communicate. They may give misleading statements. They may have problem speaking out loud or too loud. They may, if they're verbal, be brutally honest to the point of being blunt or rude. They may not acknowledge physical pain or trauma. Some are hyposensitive. They may not be able to communicate the extent of trauma due to lack of understanding of what's normal, what's healthy. And when you're getting a history, obtain the history from both the patient and the caregiver at the same time. Directly address the patient, reorient the conversation to the patient, establish how they communicate yes or no, and you can ask that directly, or you can show how they can answer those questions. Keep questions short, direct, and simple. If you can ask questions that are answered with a yes or no, so much the better. And avoid multi-step questions. Avoid the kind of questions that I'll give you in your paramedic test. Look for examples of spectrum disorder activities, movements such as swaying, tics, or repeated phrases. When you're examining the patient, don't force eye contact. If you're going to use a pain scale or pain assessment, try to keep the caregiver involved in this, because the caregiver has been dealing with the patient for a long time, and so the caregiver can ask the questions in the right way. use step-by-step explicit communication to the patient as to what they're going to do, what's going to happen next as you're examining them, and what's going to happen next. In consultation with the caregiver, you can show the examination on a stuffed animal. We often use animals for all little kids to say, well, I'm going to examine your Teddy first. I'm going to put my stethoscope on Teddy. See, I can hear Teddy's heartbeat now, that kind of thing. And reward completion of tasks. I don't know if we should carry, treats or not, but this is the thing. So, okay, that's a very brief but necessary going over of these of the kind of thing, with a very brief thing of special needs. That's a whole, it's probably a whole other lecture, but required for your OTEP upgrade. Did any questions pop up in the
Yeah, there was one regarding fever and the midazolam dose, which was we talked about that in there. Then the next question is, Croup only has Decadron as a steroid treatment. You spoke to this, but the question is, if Decadron is not available,
yes,
would Solumedrol be appropriate as an alternative?
yes, it's and it's 2 milligrams per kilo.
Yeah.
It would be now. It's my desire. I need to negotiate this with one of my MPD assistants. I believe that we should convert all of our steroids over to Decadron, and I'm gonna try to do that by in the next iteration of the protocol, which will be like August. And then there won't be any confusion, but the Decadron is actually cheaper as well, which is an interesting thing. And Decadron is used by almost all the agencies in this entire area for all needs of steroids. So I think it would be a good choice, and I like to simplify your orders. Of course, the minute I do that, Decadron will come into it'll run out, and you won't be able. You'll have a drug shortage of Decadron. Remember, out there right now, we're having a drug shortage on ketamine too. So ketamine is going to be harder to get. Any other questions or any other thoughts about this? I think I've taken up about 80 minutes of your time. Remember, Dr. Gadbois will be giving the case reviews toward the end of the month, the 4th Tuesday. All right. Thanks for attending.
Yeah. Thanks everyone for coming.